What did you know about trying to get pregnant after having a miscarriage? Hi, friends. I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. So I'm a fertility doctor. And I'm also somebody who went through 4 pregnancy losses myself. So this video is very personal to me because I know all the questions you have, how much time feels stolen from you when you've had a pregnancy loss. And my goal is to give you some information to know what to expect so that you can approach the next steps from a place of knowledge. Before we dive in, I just want to say thank you for being here. Please consider subscribing to the channel, liking or sharing the content, and ask questions below because a lot of our videos come from the questions that you ask here and on the community page. In addition, you can get more information from my new book, The Fertility Formula, which you can buy anywhere books are sold. The short answer about when you can try again after having a pregnancy loss really depends on how far along you were and what type of pregnancy loss you had. And you may not even have known that there's multiple types of pregnancy losses that can exist. So let's talk about them, talk about treatment options and what you should know, and then how we approach the next steps, physical recovery, and what we should get tested beforehand if we should. So the first type of pregnancy loss is what we call a biochemical or a chemical pregnancy. So I really am sick of having people be told that a chemical pregnancy doesn't count as a loss. It absolutely does. A chemical pregnancy means that you are ovulated, the egg was fertilized with sperm, and an embryo was formed, and it started to implant. We know that it started to implant because you got a positive pregnancy test. Pregnancy tests check the hormone HCG, human chorionic gonadotropin, which is only made from a pregnancy. Now, HCG is what you test in the pregnancy test. A chemical pregnancy means you got a positive pregnancy test, whether it's urine or blood, but then this hormone level dropped and you started bleeding. So it was before you ever got to that 6 week mark or saw a pregnancy on ultrasound. So you were pregnant in your blood, you had a pregnancy in your uterus. It was a real pregnancy. It was just a very early loss. Typically, you know this is happening because you get bleeding and there's only a small delay to your period. A chemical pregnancy loss doesn't tend to disrupt your cycle very much. HCG talks back to the brain and prevents the brain from sending out FSH, which is what's needed to get a follicle to grow. So you're not going to ovulate when you have HCG present. So if you, let's say, were pregnant for a week and then you started bleeding and your pregnancy test was negative, this would be considered a chemical pregnancy. Your pattern of ovulation will shift. So if you had a perfect 28-day cycle and you always got your period, we'll say like the first week of the month, well, this added an extra week in there. So from here on out, it should stay in this 4 week pattern, but now it would be the second week of the month instead of the first because you essentially had this paused week where no FSH was sent out. But immediately upon the HCG dropping, having the bleeding, your brain will be released from the suppression, FSH will be sent out, and then a new follicle will start growing pretty immediately, stopping the bleeding just like it would for a menstrual cycle. Back before we had urine pregnancy tests that were so good and now they can detect very low amounts and we had less awareness, this might be construed as just having a week late cycle. So if you weren't testing even, you might just think, oh, my period is 5 weeks instead of 4. So a chemical pregnancy loss can be mistaken from a late period if you are not testing. But again, if you have any of those increase in progesterone or first trimester symptoms, sore breast, nausea, sensitivity to smell or taste, aversion to foods, extreme fatigue, consider taking a pregnancy test so you know what's going on. We don't require any additional testing before trying again. I don't make my patients wait any amount of time. In fact, the early pregnancy loss study, which is a landmark New England Journal of Medicine study, showed that you have a higher rate of getting pregnant even in the immediate cycle after a pregnancy loss. The one thing to say here, though, is if you have multiple pregnancy losses, even if they are chemical pregnancies, we should get an evaluation for recurrent pregnancy loss, which includes structural evaluation, especially the inside of the uterus and the fallopian tubes, and blood testing for genetic, autoimmune, or clotting factors. So 2 or more pregnancy losses qualifies you for a recurrent pregnancy loss evaluation. Kind of second into the category of pregnancy loss become different pregnancy losses that are all intrauterine that we have identified. So we have a traditional miscarriage. We call it a spontaneous miscarriage, meaning you have a pregnancy, it has been seen on ultrasound, and then you start bleeding and you pass the pregnancy. The bleeding might seem just like a heavy period, it might be a little bit clottier, but essentially your pregnancy symptoms go away after and your HCG will drop. Now, the further along you were, the higher your HCG was, and the longer it can take for this to resolve. It is very important, in my opinion, that you get a negative pregnancy test before you start trying again, because sometimes little remnants of placental like tissue can be left behind, and those can continue to secrete HCG. And they are highly inflammatory inside the uterus and they can cause scarring. We don't want to take a bad situation, which is having a pregnancy loss, and have it compound itself by now having a uterine factor. So, if you are trying to get pregnant again, we want to make sure that that pregnancy test gets to 0 or negative before you start trying. Usually, this will happen within 4 to 6 weeks. And if you are still having a positive pregnancy test and it's been 6 weeks from your pregnancy loss, please let your doctor know, because we would want to do a blood HCG and potentially an ultrasound or a saline sonogram to see if you have something called retained products of conception. So, spontaneous pregnancy loss doesn't always need evaluation if your levels get back down to normal. And I don't make patients have a normal cycle in between, but I do want that negative pregnancy test. And then you'll usually be getting a period right around that same time, and then you can start trying. But if you have that persistent positive test, even if you have bleeding or a cycle, that needs more of an evaluation, and we need to wait to get pregnant. A missed miscarriage is similar, except you're not bleeding. So you go to your OBGYN. This is when you have an ultrasound and you might have an empty sac that can be considered a blighted ovum or an anembryonic pregnancy, or you have a pregnancy that stopped growing or a pregnancy that has no heartbeat. This is a missed miscarriage. This is a circumstance where we have to make a decision. Are we going to expectantly manage and hope your body passes the pregnancy tissue? Which, if it does, great. But if it doesn't, we then will require medical intervention. A pregnancy that's no longer growing inside your body can cause what's known as a septic miscarriage or an infection. Infections inside the uterus are highly problematic for uterine scarring. It's like a breeding ground to destroy the functional layer of the endometrium and cause scarring. So we don't want to get to that place. So more often, we're talking about two main options to manage this. One is going to be Cytotec, which is Misoprostol. This is going to cause progesterone to drop and cramping of the uterus and typically causes you to expel the pregnancy products. I hate this option. I mean, I've had it. I give it to patients, but it causes quite intense cramping, and you should know this. You should be prepared. It can cause nausea, vomiting, very severe pain. You just should be prepared for that, meaning you don't have something to go do. You're at home, you have support, you have somebody with you. If you have extremely heavy bleeding with this that's not stopping, you would then need to go to the emergency room, and that is considered an incomplete miscarriage, where you started having a miscarriage, but there is still placental or pregnancy tissue inside that is continuing to bleed. That can become a pregnancy emergency. When you have that, you would then need to have a D&C or a dilation and curettage. Now, that is the other option. Just when you see a missed miscarriage, is either some type of aspiration procedure, which can be done in the office, or a D&C, which is still an aspiration procedure now. It's with a suction. D&C is what is standard, whereas old school, we did a curettage, which was like a sharper instrument. Depending on how far the pregnancy is, might determine what you can do. So pregnancies that are really early, honestly, we can usually do with a cervical block to numb things and just right in the office while you're awake. If you're nervous or anxious or you're further along, we're going to need to be in the operating room so we can have a bigger catheter inserted, and we might need to attach it to that suction device to get enough power. Essentially, with a D&C, we are removing all the pregnancy contents. It is going to more rapidly drop those HCG levels most of the time and have less overall bleeding than often using misoprostol. So it can be a faster way to get over it. No procedures without risk, though. So there is small risk with the D&C. There can be the risk of perforating or having a small hole in the uterus or scar tissue afterward, although that is ultimately less common, especially if we're not using the sharp instruments and if we're not in the setting of an emergency. So again, infection and heavy bleeding are going to increase that risk more because we have to do what we need to do to get you safe in the moment, even if that means uterine damage later on. But most D&Cs after a pregnancy loss are not going to predispose you to uterine scarring. And I've had a D&C myself, and I will say that I preferred it to misoprostol both mentally and physically, but ultimately it is up to you, and both options should be presented if they are appropriate. There are certain times where only a D&C is appropriate. Again, in either of these options, we're going to want your HCG to get down to 0. So we're going to see a negative pregnancy test. That can take, again, 4 to 6 weeks. And if it's still positive, you need further evaluation. That is going to be more common with misoprostol than a DNC, meaning typically with a DNC, we are getting all of the pregnancy contents because we're able to do it with ultrasound and we can see. With misoprostol, your body's in charge of expelling it. And depending on how strong that pregnancy implanted, some of the placenta may be less likely to detach. So I would say I see retained products more common from misoprostol, especially if you had to use it multiple times, less commonly with a DNC, but it can occur in any circumstance. Similarly, anytime we had to induce the miscarriage to happen, I want to evaluate the uterine cavity again, even if you've only had one loss. So if you needed misoprostol or a DNC in any scenario, I now want to do a saline sonogram to make sure the inside of the uterus has completely healed up, that there's no retained products of conception or scar tissue, or even a birth defect or something that caused the pregnancy loss before we try to get you pregnant again. So I add in an extra layer if we needed management of the miscarriage before we jump into trying again. So we would want a negative pregnancy test and we would then want a uterine cavity evaluation. The same rules apply though. There's no set amount of time to try. Once you get that negative HCG and we know the uterus is normal, everything should resume when it comes to ovulation, however it was before. None of these options should have long-term harm unless we did develop some scarring of the uterus. Certainly, it's important to say that you can have pregnancy loss later term, so second trimester losses and beyond. If you went into, pre-viable labor and you needed a manual extraction of the placenta or a DNC for that, scarring is much more common the further the pregnancy was because the placenta was deeper in invasion. So those are also circumstances where I'm conservative and I'd rather get a saline and feel good about it than just assume things are normal and deal with infertility later. If your doctor doesn't recommend a saline, it's at least worth asking or advocating to see if that's an option for you if you fit into that circumstance. And then it's worth a quick mention of ectopic pregnancies, which I had one myself too. An ectopic pregnancy is a tubal pregnancy or an extrauterine pregnancy. They are non-viable pregnancies that can become another emergency of early pregnancy. Ectopic specifically because the fallopian tube can rupture if it gets big enough. This causes intense, severe abdominal pain and heavy bleeding inside the abdomen. You might have to go to surgery quite urgently to remove the tube or repair it. And obviously that can be very traumatic. So if we diagnose an ectopic pregnancy, sometimes you can wait and trend levels if you think it is resolving. You only can do that where you have very close medical management. Second is going to be an injection called methotrexate. And methotrexate is a folic acid antagonist. And remember, folic acid is important in early cell division and early pregnancy. So if we block that, the cells cannot divide and you will have a loss of the pregnancy most likely. You have to follow methotrexate pretty closely with HCG values 4 and 7 days after, make sure it's responding. You could still have a tubal rupture even after getting methotrexate, so it's really important to nuance about that. Or if we know where the pregnancy is, you could just go have surgery and have it taken out, whether it's the tube or just the pregnancy. It will depend on location, size, and surgeon. Now, methotrexate, because of how it blocks folic acid, can live in your system for up to 3 months. And so we recommend 3 months pause before you get pregnant again. And this is regardless of how fast or long it takes your HCG levels to get back down to 0. This is one of those circumstances. Again, I had methotrexate. It's not fun. I felt like I got hit by a truck, which kind of took me by surprise from the medication, how it impacts all of your cells. But it did resolve my ectopic pregnancy. And then I did have the 3 months before we could get pregnant again. And that was time that I really took to say, I'm going to get myself as healthy as possible, not in an attempt to, quote, get pregnant, but to take charge of the situation, and really started to learn more about inflammation and insulin resistance. And when I started changing my lifestyle, that ultimately led to me getting pregnant. Sometimes having that mental forced break can be really good. And it's worth saying that if this is you, my arms are wrapped around you, big hugs. Having a pregnancy loss makes you doubt things about your own body, your future, what you saw for yourself, and you're not alone. Please get support from somebody throughout this journey. It doesn't matter who it is, but you need somebody you can be your open and honest self with. And please have a provider who you trust, who's going to answer your questions, explain why some of the things I'm saying may or may not be appropriate for you. And this is a guide for you to make decisions about your care and help advocate for your system along the way. I see you. I am you. I love you. Huge hugs. Thank you guys for listening. As always, you can get more on the As a Woman podcast, or you can follow along on Instagram at Natalie Crawford MD.